But what blew me away was that 31.8% of patients have a different lens in each eye. So either it's a corneal or a scleral. Now I knew that could be the case, but I didn't know it was this number of patients. Now, understanding keratoconus itself is important, but equally important is understanding what else travels along with it. And the aim of the work that I'm going to present today is dedicated to all the patients with keratoconus. Now, the aim of this presentation is really to identify conditions associated with keratoconus that are of concern and separate those from the ones that are not of concern. And where we do have concern, just to discuss some strategies and guidance and support and reassurance that we can provide. I wanted to do that by using the results of a study that we've done over a two and a half year period, which is a questionnaire, a patient-centered questionnaire. And also I wanted to ask for your support for future work so that it becomes a bigger project. So I'm not going to talk too much about keratoconus because I think you're all experts. Either you have keratoconus or you're living with somebody with keratoconus. But I wanted to focus on what we were looking at and why we were looking at it, which is really the background of the patients involved. Now, acknowledgements are usually at the end, but for me they're always at the beginning. And I wanted to acknowledge the support of Pramajit Gatora, who's a deputy head. So she collected the data with me. I saw over half of the patients myself, almost a 2/3, and she saw the remaining. So because we are a large hospital, it was important that the data collection was limited to a small number of people in the beginning. Professor James Wolfson is an incredible gentleman at Astor University who's helped us to look at the data. Mr. Barua is our consultant ophthalmologist, corneal lead. Dr. Martin Cardle again helped to design the questionnaire, and then he saw about 20 patients and thought this is too much work. And then, but again, he's very much part of the team involved. And also Professor Roz, a senior consultant who has made some excellent suggestions about how this project could be made bigger and more scientific. So I will come back to that. Now, everyone has a story to tell, and everyone has people who've had a big influence on their career and their life. And for me, it's a gentleman named Professor Neil Charman, who I did my PhD with over 20 years ago, which was actually on keratoconus and things that affect keratoconus. And what happens is as time goes on, you become very clinical. You're very much involved with the patients and you forget the scientific and the theoretical side. But I will always be grateful to Professor Charman, one of the finest people to walk on this earth. And we then have Mr. Tony Sabal, the late Tony Sabal, who was really the scleral lens expert in Birmingham, who set up the service, and we have a workshop dedicated to his name, and we're really trying to continue the work that he's done. Briefly, my own background, I've been the head of department for about 16 years, but I've been in the NHS almost 30 years, despite my youthful good looks. And so I really understand from this end as well as from the patient's end. And you have the normal long waiting lists, etc. But also you have a lot of uncertainty about what may happen next. You know, if other hospitals close without any discussion, any involvement, the implications for us, the duty and responsibility to our own patients, and then how much do we commit to other things? So the normal things. But the main challenge isn't, I'm sensible enough to know that we would never ask for more money to reduce the waiting list. All we normally ask for is to be able to replace people who've left in a timely manner, because contact lens fitting is a skill, it's an expertise that needs to be built up with time, and it takes time to train people. So aside from that, I do believe that the patients we have get the best possible care you can get anywhere, and the appropriate lens choice is made in each situation. We're not under any pressure to fit any kind of lenses or make any decisions. We are a hospital, we will do what is right for each patient, and that's the best part of the job. So I just wanted to ask this question: have you ever felt misunderstood? What would you say?
It's a big one.
It's a big one. It is. It is. And what I would say is that I've been managing keratoconus for about 30 years. And one of the privileges of that time has been seeing teenagers grow into adults and come in with their own children. So last week I saw somebody with a 16-year-old, and I remember seeing him as a patient. And in the last 3 decades, there have been incredible advances in the contact lens designs, in the materials, in the surgical processes and the medications that are used and the healing processes. But also we now have collagen cross-linking, which has been a game changer, and the evolution. But my question is, how much further forward have we moved in understanding the patient with the condition? And that's what this is all about. And so for many, many years, I've wanted to do this work. But the real trigger, as they say, was really one Saturday afternoon when I met a young man who had kind of been seen as being someone very difficult and quite demanding. Now, whenever there is a complaint, I have to be the person who's, we take complaints very seriously, and touch wood, we've been very, very lucky. We rarely get any complaints because we're so good, but we have a very good system where everything is investigated thoroughly. What did we do wrong? What could we do better? So what tends to happen is, especially support staff who have to answer the phone, etc., they will always give you the heads up. This person's very difficult. We really tried to help them. Nothing is, And I remember meeting him, and I figured straight away who it was. And I remember saying to this young man, why do you always change your appointments? You're always phoning and you're always worried, and then you either don't attend or you want to change the timings. And he told me the reasons. And that's when I realized, do we really understand the individual? So this young man was obviously very anxious, had been through a lot of trauma, and it was very difficult for him. So even though he would have an appointment, he was trying to explain, I cannot wake up early in the morning. I have to take medication. I need an appointment later in the day. On the other hand, you have very stressed staff with very few appointments. The communication wasn't there, and there was nothing on the records to indicate the reason. And that's when I thought, I'm starting this study, even if it's on my own. So this is really about wanting to understand our patients. And this is really the first stepping stone. And this is one of those stairways that either go up to heaven if you've done really well, or if one wrong step and you're in trouble. So hopefully we will all go in the right direction. So just very briefly, keratoconus is a corneal thinning disorder where the cornea changes shape, and astigmatism and visual rehabilitation is required, and you're all experts, various kind of contact lenses. The detection is now far better. It is earlier. And the management, again, I'd like to think, again, with my colleagues from more fields, that we do what we can with the resources that we have. So if we look at the hospital setting, so these are really the other scenarios that we have, and the reason why perhaps keratoconus isn't where it should be. So glaucoma is a condition that you may have heard of. Have people heard of glaucoma, where the pressure is raised, and unless it's detected following an eye test, it can cause blindness or damage. So now in the community, if somebody's parents had glaucoma or siblings, from the age of 40, they're entitled to a free eye test. My late father had glaucoma, so I know that I can have an eye test, and as my siblings can. So there's a good understanding there. Within the hospitals, again, there's a good setup. You have the glaucoma consultants managing complex glaucoma, and then you have sort of private providers supporting the non-complex areas. No questions asked. Medical retina, again, we know that diabetic retinopathy can affect the working population, so there's a good screening program. And there's an urgent referral pathway that community optometrists would use. Equally with macular degeneration, we know it can be blinding. There's a pathway that can be used. With detached retinas and vitreoretinal, it's very similar. But what about keratoconus? A lot of optometrists don't actually know where to refer people for collagen cross-linking. It's not very clear. And once people have had surgery, again, the queue to the contact lens department is kind of pretty much down. So a lot of the focus tends to be on those blinding conditions. But if people don't have their contact lenses, the vision can drop to a very, very poor level very quickly. So the study took 2 years, or actually 2 years and 4 months, and it was face-to-face during contact lens appointments. And the data we were collecting was really various different aspects of patient care. So it was quite a detailed questionnaire, and what I will do is discuss the questions that we asked, the kind of results we obtained, and some of the learning points from that. So we are in the process of writing up and publishing when we'll have a detailed sort of literature reviews, and I will share those with Anne and Steve. So we had 579 patients diagnosed with keratoconus, and about 14% were part of the keratoconus support group. So this is really interesting because the vast majority of patients were not part of this group. So it's a totally separate cohort, which is interesting because when people are part of a support group, it means they're very well engaged, they're very educated, so this is a separate group, and therefore their responses are all the more interesting. About 30.5% were aware of the support group, and I think this really increased. We presented the data for about 125 patients at the Royal College of Ophthalmology as a poster, and hardly anybody knew about the keratoconus support group. And I remember getting in touch with Anne, who organised posters to be sent, and we then, tried to advise people. So people were aware of the group. This was different to what I was expecting. 69% males, 30% females, and the average age was about 37. The age of diagnosis, and we used the reported age, so the patients told them when they thought it was diagnosed, was 23, which fits in with our theory of late teens, early 20s for diagnosis. So if we look at we wanted to look at each age group, and we've only got very few people under the age of 18, and this is just coincidental. It was a clinic running on a certain day of the week, and we had the vast majority of patients, in fact 60%, seemed to be between the ages of 20 and 40. Again, if we look at the age distribution, a few patients over the age of 60, mainly in that sort of age group in the middle. So I'm always interested in the different generations and our kind of thoughts and attitudes, and I really believe 50 is very young, or 55 is even younger, but younger people think older people are very slow, and older people think younger people are lazy. I mean, none of that is true. We all have our pluses, but it's really interesting. So in the group out of the silent generation, as it were, we had one person, and then we've got none of the alpha sort of it's mainly the millennials who seem to be in the group. So if we look at the patient base, again 265 people born between 1981 and 1996, and that's our kind of cohort, and the age range wide, 16 to 82 years of age. And again, I just wanted to be able to look at what ages are the patients, what kind of generation do they fall into, and also in terms of how do they engage with social media, for example, or how do they obtain their information? Is it through newsletters? Is it through TikTok, etc.? So this was one of the questions, and this is a really important question because I do feel that there is some stereotyping about the keratoconus support group. There's almost this feeling that people haven't been able to achieve as much as they could have done due to poor vision, or sometimes the group's even seen as being a high cost kind of a service for hospitals. So now when somebody has a cataract removed and they have a lens placed in the eye, that appointment generates a lot of income for the hospital. Whereas if someone is supplied with a contact lens, the hospital doesn't get paid very much, and also in a lot of the cases the hospital has to pay for the cost of the lenses. So there's always been this stereotyping, and I really wanted to understand what's the reality. So we asked these questions about the educational background, and it was very surprising. Over 50% of the patients have either a degree or a postgraduate qualification. So, and this has been my impression for years. So by postgraduate, we're talking about a PhD or doctors or pharmacists, etc. And again, 20% are a school or college, 20% are doing BTech. So everyone is either in the education system or wanting to be in the education system. And again, if you look at the degree and the postgrad, it doesn't matter what people do. The point is everybody wants to do better and they want to be able to, achieve. So the message that I would have, and I know we've got people of varied background, it looks like we've got very experienced people here. If someone's been newly diagnosed with keratoconus, it's important that they let their school or college know. They must let their tutor know, let the pastoral care teacher know. I think that's important. And there's always a letter with the diagnosis. Provide that as the evidence as early as you can. Now, we're often asked to provide letters during the exam time with support for extensions, etc. And there's a lot of limit to what we can do, especially in the exam season. So I would say, when you come to your appointments, especially if you're young, explain how you are struggling. So in my town, we had the blackboard, but it's all interactive and it's whiteboard. So if you're struggling with glare, tell us at the appointment so we can record it. Because when we provide information letters, we simply provide a summary. So if in the last 2 visits you were fine, that's what we will write. Whereas if someone said, I sit at the front of the classroom, I'm struggling, the glare, etc., I'm struggling with the volume of work, please let us know. That's really important information. And the ECLOs are, the Eye Clinic Liaison Officer, are just incredible resource. So I would say, particularly to students, particularly to young people at university, plan ahead. So I know it's Easter kind of time coming up, and then there will be GCSEs and A-levels, and that's when a lot of work is done. But if you're relying on your contact lenses and your eyes are getting drier, and if you've used your lens for 14 hours, you might not be able to wear it the next day. So you need to be ahead of the game. You need to be more organized. And honestly, the sky is your limit. Keratoconus should not hold you back. Just the support is there. So please plan ahead. The other thing we wanted to look at was the employment status, and especially with the location we're in, the general feeling that people are dependent on the system's been there. But what I've picked up in the last 15, 20 years is everyone's either working or wishes to work. And we know that because of the request for support in remaining in employment. So that was the question we were asking. And 73% were employed, 22% on benefits. And we had also patients who were employed but on low income benefits. And so this is my impression. For some reason, I see lots and lots of teachers. Maybe it's just a little bit of a fluke. So, we've got teachers, you've got optometrists who've got keratoconus, pharmacists, entrepreneurs, support workers, people from all walks of life. And again, that sort of ties up with what we're finding. So we've got a highly educated, people are making a big contribution to the education sector, a skilled workforce. And contact lens correction is required to be able to do the work and maintain employment and functional independence. Without contact lenses, if you take those lenses away, a lot of the patients that I know actually fall easily within the partial sight or blind register. And that's the message we're trying to get across. So you've got a doctor who can't actually work without their contact lenses, or a pharmacist who can't prescribe, or a teacher who can't teach a class of children. So that's really important. Now, should you inform your employers about your diagnosis? I mean, I don't know what experience people have. With the education system, I'm very clear, absolute yes at the earliest opportunity. So this is a hard one, and you have to base it on your own experience. And I know we have sort of various acts where everyone is meant to be treated equally. If I had my managerial hat on, I know I shouldn't say this, but if someone's mentioned they're struggling and it's hard to cope with the work, if there's a promotion coming up which requires more responsibility, more work, does that make it easier or not? I would say that from experience, be clear about what outcome you would like. So if you want adjustments to your workplace because the lighting levels are disturbing you, or the space within the office is not ideal, then definitely ask for support. But just decide yourself. But be clear about the outcome and be willing to meet people halfway. Sometimes we do have employers speaking to us saying, look, we cannot do that. What's being asked is completely unreasonable. But and there have been occasions where I've kind of felt that I do understand that. So always be willing to meet halfway and ask for the adjustments that you need. So driving status, we found that 68% of people were driving, and keratoconus tends to affect confidence, I think, more than anything else. It's the guidelines that you must be able to read the number plate, and the responsibility to regularly check the number plate really lies with the patient. Because certainly in winter, it's dark at 4 o'clock. the lighting levels change quickly, and depending on where you are, you may be within the driving standard, you may not. So we leave that responsibility to the patient. So that's the number who were driving. So from our guidelines, that's the College of Optometrists, so we have to inform the patient in writing if they are not suitable, if they cannot drive. And then the duty is on the patient to inform the DVLA. If you do not agree with the optometrist, then you can always get a second opinion. But I think guidance is that while you're getting a second opinion, don't drive. The optometrist can inform the DVLA if they feel the patient, the public health is at risk, or someone is driving who shouldn't be. But the onus is very much on the patient. And I would say just measure out from your front doorstep how far the number plate is, and just check regularly. And now we're just going to talk about collagen cross-linking very briefly. I'm sure you're all kind of familiar. It's a treatment which is used to toughen the cornea so it doesn't thin and bulge. And it's a first line of treatment now where the keratoconus is progressing. And its really aim is to cause stabilization rather than improve vision. And just really, basically we're toughening the fibers up in the cornea. Now, 38% of the patients in the group of 579 had had collagen cross-linking. And the question we asked was, did the collagen cross-linking help? I should have put in the third question, yes, no, or I don't know. And because the I don't know wasn't there, people were pushed to decide. Now, so that's the number who'd had collagen cross-linking. Now, I've met many people who've said over the years, if only we would had the opportunity to have collagen cross-linking, we missed out. I don't know if there's anybody who feels like that here, had that been there earlier. I'll be interested to know. So we asked people, do you think it was helpful? What number do you think found it beneficial? Would you say, just sort of pick a number, who said, yes, helped, it helped. I mean, sorry, did I hear something? 20%. 20% thought it was helpful. Anyone else?
I'd say it was 50-50, because a lot of the misconception with collagen cross-linking is that it improves your eyesight, and it doesn't. And sometimes it makes it worse. But you should be able to wear a contact lens. It's the misinformation around what CXL is actually for that's the issue. I'd say 50-50.
50-50. Okay, that's really, really interesting. And anyone else who feels they've missed out and should have had it? Okay, so again, it's very interesting. It was 54% that said it was beneficial, absolutely spot on. And 45 said it wasn't beneficial, and I found that really surprising. I thought that, about 80% would say, great, I've had the opportunity. So this is really interesting. And I suppose the patients that we saw were in the contact lens clinic. Maybe there are people who are just fine, and then they go into the community, and we haven't caught those patients. It's just, and it is about expectations. I think that the expectation is that everything will be fine. For me, it was really interesting to look at the age group of the patients, because a lot of the older patients have missed out. So the patients who thought it was beneficial were about 28.4 years of age, and those who didn't were 29. So it's really the same age group who think that, and the people who kind of missed out or didn't have the collagen cross-linking were 42 years of age on average. So this is really interesting. At one point, we thought people, 70-80% would be, it's really amazing, we've had it done. So that's really important to take into account. Have you missed out? I don't think so. I think you are where you were meant to be in your journey. So, and then we looked at this one, and this one was a real surprise to me. Having done this for so long, this was a real surprise. So, quarter of the patients were using glasses, and some of them using nothing, were unaided. And I'm sure that many years ago it would have been 80% in contact lenses. Glasses just didn't work. So is it the effect of the collagen cross-linking that's contributing to people being able to use glasses? Rigid gas permeable corneal lenses, about 45.9, 46%. So, but what blew me away was that 31.8% of patients have a different lens in each eye. So either it's a corneal or a scleral. Now I knew that could be the case, but I didn't know it was this number of patients. So, and because we are a hospital, we are not advocating for any kind of a lens. We fit what works for the patient, okay? So my view is the best lens is the one that's right for you. that gives you the best vision and is comfortable. So now there's always this discussion about the Holy Grail, the best lens, the amazing lens. So what does that mean? Does that mean that we have two concepts of the Holy Grail? There's a Holy Grail that's the best lens for the right eye and one for the left eye. So that was very interesting for me, that actually, you know what, guys, there isn't a perfect lens. The two eyes may behave quite differently and need something quite different. So that was very interesting. So, and again, people who'd had collagen cross-linking, what they needed afterwards wasn't that different compared to those who hadn't had the cross-linking. Very interesting, because it's a larger number of patients we were looking at. Again, we asked people what drops they were using. 72% were using eye drops. A lot of people were using artificial tears, and literally almost 90%. And this is good news for obviously the artificial tear industry, because they know that the products are very beneficial. So a small number were using steroids or anti-allergy drops. Okay, so a large number of patients were using drops with their contact lenses. So this was really an area of concern, and this is really the reason why I'm here today. We asked about mental health, and this is a basic questionnaire. In future we will do more detail. Well, have you been diagnosed with any mental health conditions? If the answer is yes, is it depression, anxiety or schizophrenia? And any other conditions specify? And almost 20% of the patients had a diagnosed mental health condition. I didn't know that. I've done this for 30 years and I didn't know that 20% of our patients have a diagnosed condition for which they are on medication. Depression was 14%, anxiety was 17%. We then asked people if there was an undiagnosed mental health condition. So in other words, they hadn't had any support and they felt something. And again, almost 10% admitted that they feel strongly there is an undiagnosed condition for which they haven't had support. So almost 30% of the patients, and that's a huge number, 19.6% diagnosed had a mental health condition, depression and anxiety. And the interesting thing for me was most patients only provided the information once they were asked the question. I know this because I did the study. You know, almost just under 2/3 of the patients, if you ask the question, people would lower their heads and say yes. It's unfortunate that stigma around mental health exists still today. We have to support one another and help create a culture where everyone feels safe to speak openly. And I felt for quite some time, people are not difficult or demanding. The communication isn't kind of there, and people are not coming. And in the medical records, so we normally say, how is your general health? And the focus tends to be, is there any diabetes? Is there any blood pressure? And people say, fine. They will never tell you that and that's really important. And the reason why it's important is because the medication that people are on for depression, for example, things like sertraline or other medications, antidepressants, have visual ocular side effects. Dry eye disease is a very common one, a well-known one, blurred vision. Pupils can dilate with some of these antidepressants and cause glare. Now we know keratoconus causes glare or early stages of glare, and we know vision can be blurred because the power needs changing. So, and also there is a very rare side effect which is called angle closure glaucoma. Now in the contact lens clinic, we don't check the back of the eye. We do the contact lens fitting and we advise people to attend their community optometrist for the back of the eye, the pressure check, the visual fields, etc. We focus on the contact lens side of things. Especially patients who've been discharged by the consultants, there's an onus to regularly be checked, but it's just so important to tell the optometrist, the ophthalmologist, whoever, if you're on medication, again, commonly prescribed medication, things like Valium, diazepam, cause blurred vision, glare, similar kind of symptoms that you might associate with the early keratoconus. So if you have keratoconus and are taking these medications, it's so important to tell the optometrist. You will be given support and advice. We have excellent ECLOs, we have excellent team of people, and I promise you that the whole approach will change. And I'll tell you the reason. Now, every member of staff who works for the NHS has to have mandatory training. And Anil will say, yes, we all have this mandatory training that comes around so quickly. And it's really CPR. And, it seems to, we all have this kind of percentage out of 100 where we are with our training. And there's a very important one on safeguarding adults and safeguarding children. If you know someone is not well and needs support, your approach is completely different. And we can create safeguarding alerts on the system. So on the system, quite often it will say whether someone is allergic to penicillin or whether someone, has certain health conditions. So those can be created so we're more aware. If someone's missed an appointment, we won't just discharge them. We'll be a little bit more careful. So that's important. And also the side effects of the medication can be discussed and we can be more aware. Now, in our hospital for children who have learning difficulties, we have a special SEN clinic, and I'm sure, Sunil, you must have something similar at Moorfields, where there's a bit more time allowed. So, rather than a half an hour, it's a 40-minute consultation. So where we know someone is struggling, perhaps a little bit more time can be allowed. And also referral for counselling support. So you must inform me, I cannot emphasise this enough. And again, I brought this slide up again. This was my experience, and also my colleague Pramjit, who is the deputy head, said to Waheeda, there were a few surprises. Do you know so-and-so is on so much medication? And so it's really interesting where, make us do the work. Just tell us if things are not right, and so we can actually provide the support that is needed. So please raise the alarm. If you suffer from a mental health condition, diagnosed or undiagnosed, discuss it with your GP, optometrist or ophthalmologist. Support will be provided. And one of my colleagues said, actually, when I sort of discussed, and he said, Waheeda, you have to put in a slide to say, we don't have any tea breaks. We only have 30-minute lunch. We're on this treadmill and we don't always pick things up. You must tell us. And I said, I will mention that. So that was an area of concern. And then we also asked general health questions, like do you suffer from diabetes, blood pressure, connective tissue disease, diabetes, the kind of things that you read in the literature about. Now, it's important to remind you that the age group was from 16 to 82. So obviously as people get older, type 2 diabetes, etc. can creep in. So we wanted to look at that. And this wasn't really an area of concern, especially heart conditions. Is there any relationship, connective tissue disease? We didn't find that, okay, which is very reassuring. So I think with diabetes, it's important that you're aware. It can cause some visual disturbance, but if somebody is a diabetic, and even if they're keratoconic, you must have your diabetic screening every year. And if the photos are not clear, then you will be referred to a slit lamp clinic, and that's again separate. And diabetic retinopathy can cause damage to the back of the eye, so it's important those appointments are kept. And if there's history of glaucoma, again, have regular eye tests and make sure that things are picked up. And hypertension, all of these things can affect the retina as well. But these did not stand out as any areas of concerns because of keratoconus. Family history, again, a well-known one. Almost 28% had a positive family history. This is something we will look at in detail. But I would say if you have family members, so if make sure you alert the cousins and other family members to be aware, so screening can happen, so the optometrist is aware. So a lot of the parents are actually quite anxious. Do not worry. I always say just mention it to the optometrist and then put it out of your mind. It's late teens, early 20s. And again, the recognized associated conditions. And this was again interesting. I should have, and this is a huge learning thing, so for each of these, I should have put in the option as a child. So there were people who said, I had hay fever as a child, I had asthma as a child. For me, the interesting one was food allergies, because I'm convinced people have got food allergies, but it was an interesting one to look at. We didn't ask about sleep apnea, and we didn't have any patients with Down syndrome, even though the incidence is higher. In this cohort, we didn't have any, and we're really interested to know if there's any other emerging associations you think we should look at in future. So there's one that really, so eczema, a quarter of the patients, asthma, psoriasis, slightly less, hay fever, over half the patients complained of hay fever. Food allergies, again, not very many. So the patients that I'm kind of aware of all seem to have allergies to seafood, but nothing really came up. But eye rubbing was a big one. Now, we had the Keratoconus support group meeting in Birmingham a couple of days ago, and it was really fascinating because people were talking about eye rubbing and what should we do. And I just think, we say to patients, don't rub your eyes, but sometimes we just say it. You know, I don't think we kind of really communicate it really well. And it really made me, looking at these figures, it made me look into it. So basically, I wanted to understand, what does eye rubbing do? I've been saying it to everybody for years. And so I looked, now we all use artificial intelligence, and I wanted an analogy. And I don't know if you're all aware of the woolly sweater analogy, or I don't know if you are or not. So basically, if you've got a woolly jumper on and you rub a small area, nothing will happen. Do that for you. If you keep rubbing that area, the fibers will become quite loose, quite relaxed. It'll start losing shape. And it's the same kind of thing if you keep rubbing your cornea. So there's actually trauma and damage that you're causing. And also it triggers a release of enzymes that contribute to the thinning of the cornea. And it causes, so basically the message is really simple. Do not rub your eyes. Now, and then at the group, people were saying, well, what should we do? A very good question, okay? And it's only because I went to, and I think the Birmingham meeting is going to be revived, and I'm looking forward to attending, even though it's meant to be a patient support group. And I wasn't sure, should I go? I think people should have the opportunity to get things off their chest if they want to complain about the hospital, but I genuinely wanted to learn. So I went along and I learned so much. So anyway, so I got my dear husband to be the model. Do not rub your eyes with the palm of your hands. That's the worst bit. Do not rub your eyes like that. Okay? And then, no. So do not use your knuckles. Again, that's applying a lot of pressure. Okay? That's, again, a no-no. What should you do? Well, what you need to do is use cool compresses. So in your fridge, take up a small compartment, label it, no one is to touch that area, and have some tissues there, or a face cloth or something, and keep it in the fridge. When you take your lenses out, just use a cool compress. It doesn't need to be anything expensive or fancy. It could literally be tissues, or it could be something, and that helps to calm the eye down and stops that sort of rubbing and itching. There you are. And also wash your face with cool water without contact lenses. So use distraction strategies, because 65% is a very high number. Okay, and also obviously use artificial tears, preservative-free eye drops, antihistamines if you suffer from allergies, etc. So really eye rubbing is a big one, but it has the implications are far more severe than you perhaps realize, especially if you worn lenses for a long time. Now, totally separate discussion about lenses rubbing on the eye. We won't go into that, but again, it has a similar effect. Hay fever is again a cause for concern. Reduce exposure to pollen. Somebody showed me an amazing pair of spectacles, I think Eddie. So some wraparound sunglasses. I think an excellent pair actually I've seen here. If we can, and again I've seen some patients use them. They make a difference. They do help. Okay, because it's really hard to say to young people, don't go outdoors when the pollen count is high. You know, if the tree pollen count is high or the grass pollen, and it's lovely and it's warm outside. So just whatever you can do. So keep windows closed during the high pollen count, and antihistamine and tablets.
Sorry, this rubbing of the eyes, it's really got me, because I didn't believe it caused keratinosis. You're the expert. Are you definitely sure it's a contributor towards keratinosis? Are you sure?
Yeah. Well, there's a slide that shows what it does.
The
fibres releasing
Because
the enzymes.
your little baby could rub its eyes,
Sure.
which is going to cause keratinosis in the long run.
The thing is,
long term, it's the constant doing it a lot. A baby will rub its eyes, yes, but if as a child you have allergies and particularly hay fever, and you constantly rub your eyes, later on highly likely to be diagnosed
Thanks.
with keratoconus.
All right, thanks.
That's it's the amount of times you do it.
All right.
And what tends to happen is, sorry, I didn't catch your name.
My name's Nick.
Nick, so what tends to happen is a lot of people say, but I used to rub my eyes. And the reason why young people did was because they were itchy. They were uncomfortable. It's not, and people have a lot of guilt around how it was all self-inflicted. No, because your eyes were uncomfortable. They were itchy. They were, and the awareness wasn't there. We've discussed how even now the awareness isn't quite there and the parents weren't to know. So the answer is really to use antihistamine tablets or drops and keep the eye calm. So the literature all points that way, and literature from different directions. So I think that sort of, we would say is a big contributing factor. Family history, yes, but eye rubbing seems to be. So, and it's nice when there's a clear answer. It's sort of, it is the case. So, hello.
Yeah, quite a worry. What you said is a worryingly high percentage of KC people rubbing through it. Has anybody done any surveys about what proportion of the general population with or without KC rub their eyes? And do we actually do it any more than anybody else?
I think that's a really, really good question. And for all the data, so this is really the pilot study. So for all the data, and even where we're talking about anxiety and depression, is it any different from someone with a blinding condition or sight loss? This is something that we will look at, and Professor James Wolfson will help us to look at that. But to be honest, it's important information to share. I think that the symptoms that tend to occur, asthma, hay fever, associated conditions, are known to be associated with keratoconus, and therefore, they are known to be contributing factors from lots of studies in different directions, and therefore I think people rub more than the general public. So I think people do have itchy eyes, etc., but I think we can say with confidence that it tends to be more. And again, my PhD was over 20 years ago, and I remember looking at associated factors. So there's things that you look out for. So certainly now keratoconus is diagnosed a lot earlier, and the really quite the strong aggressive type, you see young people with lots of those allergies and lots of those things. So, but we will hopefully will be able to provide more accurate information to answer your question. But I think the general view is they do rub them more than the general population. So I think avoid irritants. So this is really eczema around the eyes and things that can contribute to itching. And so just being careful for young women, absolutely wear eye makeup, but I would say invest in good quality makeup. That's really important. And I have put a really cheeky slide on. And this is, obviously young ladies don't come in with lashes that thick, but you do see them coming in beautiful with beautifully made up eyes, and you think, oh my goodness, this is your first lens. I'm going to, you don't want to ruin your makeup. So, and then they do listen. So just, you can do all of those things, but my advice would be, and especially if you have family members with keratoconus, a good Christmas present, or it would be a nice kind of a mascara, or a nice makeup, which is kind of not quite affordable for young people. So good quality products are important. So we're one hospital, one study. There's a need for lots of work. We need help from the keratoconus support group. So this is 579 patients. It's a pilot study. We want to have a detailed, well thought out questionnaire, which we're hoping that everybody can be involved in. We need to, there are certain groups of patients, for example, the glaucoma, the world diabetics, a lot is known. Everyone knows how they struggle, how they suffer. And that's why it's got to the stage where it's recognized conditions and the support is there. And I think there's a need for something similar for keratoconus. Should we change in the way we take patient history? I don't know how people feel if they were asked, are you feeling depressed? Do you take medication? Whether people might be offended or whether they think that is appropriate line of communication is something that we need to look at. Again, the clinic letters, should all the clinic letters have the details of the keratoconus support group on? But then there are many people who don't have keratoconus, and also the ECLOs, etc. So there's lots of things so I'm very conscious that well-being can become a little bit of a buzzword. What are organizations going to do about it in the backdrop of appointments already being limited, etc.? So it's something that needs to be taken into account. But the most important thing you can do to help yourself is inform somebody so that a safety alert is created. And then you know, someone can look a little bit more carefully. So now the way the documentation is, it's all pretty much electronic records. So even when somebody phones, there's a sentence typed, so-and-so phoned, I tried to find an appointment for them, I offered this. So it's become quite a defensive culture. So, but if there's alerts there, somebody will think this person's struggling, we need to try to find something, or we will phone them, etc. So it can only be to your advantage. Thank you very much for your time and attention. Thank you.